Hi, in this video we will read about evaluation of a newborn. Let's start. Most newborns are born healthy. Some 10% are sick and small and need admission to the neonatal unit for the observation and treatment. Newborns may have a different physical findings at the other time points, hence do the physical examination soon after the birth, at 24 hours after the of age and before discharge, and at the follow-up visit. Assign APGAR scores at 1 and 5 minutes. This is important that when we have to assign the APGAR score, we have to assign the APGAR score at 1 and 5 minutes. If the score is less than 7, do it every 5 minutes until 20 minutes. Okay, if the APGAR score is what, less than 7, then we have to do it every 5 minutes until 20 minutes. APGAR score provides information regarding the cardiopulmonary status at the birth and adaptation to the postnatal environment. APGAR score of APGAR score of 0 to 3 at 5 minutes correlates with mortality. However, low APGAR scores do not predict the long-term neurodevelopmental outcomes. Coming to the general observation. Carefully observing the newborn provides important information at any time and should never be missed. Assess the state of alertness, behavior, response to handling, posture, spontaneous activity, color, breathing difficulty, or obvious malformations in the baby. Ideally, observe when the neonate is in the light sleep or awake, but quite typically 1 to 1.5 hours following the feeding. Vital signs. In a sick baby, assess the vital parameters at the outset to assess the hemodynamic stability and find out if the neonate needs emergency treatment. Assessment of the size and growth. Low birth weight babies implies birth weight below 2500 grams, that is 2.5 kg, very low birth weight less than 1500 grams, and extremely low birth weight less than 1000 grams. This is very important to remember. Low birth weight 2500 gram, very low birth weight less than 1500, and extremely low birth weight less than 1000 grams. Plotting the weight against the gestational age on the intrauterine growth curve provides information regarding the status of the intrauterine growth. Between 10th and less than 90th percentile, appropriate for gestational age. Below the 10th percentile, small for gestational age. Above the 90th percentile, large for gestational age. The small for gestational age neonates have suboptimal growth during the intrauterine period, intrauterine growth restriction or IUGR. These neonates look thin and slender, have loose folds of the wrinkled skin, and have a monkey-like faces. Intrauterine growth charts are different from the postnatal growth charts. The latter assess the growth after the birth. Now let's read about this table. Newborn history and examination, format to case presentation. Okay. First one is the history. So in general, mother's name and age, parity, last menstrual period, expected date of delivery. Now, in the past obstetric history, we have to ask about the past pregnancies. When gestation, fetal or the neonatal problems, and about the current status of the children. In the antenatal one, number of the antenatal visits that she took, the tests like hemoglobin, urine albumin, sugar, ultrasound, blood group, VDRL, HIV, tetanus toxoid, immunization, supplements, that is the iron, folic acid, and the calcium iodine. In the obstetric or the medical, we have to ask about any obstetric complication if occurred, like toxemia, urinary tract infections, twins, triplets, placenta previa, accidental hemorrhage, or any fetal problems like the IUGR, hydrops, RH isoimmunization, medical problems like the diabetes, hypertension, investigations, medication, and course. In the labor presentation, onset of labor, whether it was spontaneous or induced, rupture of the membrane, spontaneous or artificial, liquor, whether it was clear or meconium stain, duration of the first and the second stage of the labor, fetal heart rate, tachycardia, bradycardia, and irregular. Now coming to how was the delivery, the place of the delivery, vaginal, it was spontaneous, forceps or vacuum, cesarean, indication or elective emergency, local, under local or general anesthesia, duration of the third stage, and the postpartum hemorrhage. Immediate care at the birth, resuscitation was given or not, time of the first breath and cry, Apgar's cord care in the passage of the urine or stool. Now coming to the feeding, breastfeeding, when initiated, its frequency, adequacy, and the other feeds. Postnatal problems, feeding problems like the jaundice, eye discharge, fever, and the current problems. Family, history of perinatal illness in the other siblings, past medical problem, history of past medical problems if any, personal or social socioeconomic status, and family support. Now coming to general examination, which the first one is immediately after the birth. What is done? We have to measure the weight, gestation, congenital anomalies, sex assigning, Apgar scores, examination of the umbilical vessels and placenta. In the appearance, we have to look at the overall appearance, well or sick looking, and alert or unconscious. Then the vital signs like temperature, cold stress, respiratory rate, retractions, grunt or stridor, heart rate, palpable femoral arteries, blood pressure, capillary refill time, cry, and apneic spells. In anthropometry, we have to take the weight, length, head circumference, and chest circumference. Gestation, assessment by the physical criteria, more detailed assessment by the expanded new Ballard examination. Classification by the intrauterine growth, appropriate and small/large for gestational age, symmetric or asymmetric small for gestational age, or signs of IUGR. Congenital anomalies, head to toe examination for the malformations, birth trauma, signs of trauma, and cephalhematoma. Common signs like the cyanosis, jaundice, pallor, bleed, pustules, edema, and depressed fontanelle. Fine, we have to look for these common signs and also for some special signs like caput, eye discharge, umbilical stump discharge or redness, jitteriness, eye discharge, oral thrush, developmental peculiarities like the toxic erythema, obscene pearls, breast engorgement, vaginal bleeding, capillary hemangioma, and Mongolian spot. Feeding, observe the feeding on the breast and check the positioning and attachment. Reflex, Moro, grasp, and rooting. Now in the systemic examination in the chest, we have to look at the shape, respiratory rate, retractions, air entry, and adventitious sound. Cardiovascular system, we have to look at the apical impulse, heart sounds, and murmur. In the abdomen, we have to look for the distension, wall edema, tenderness, palpable liver, spleen, kidneys, and any other lump, ascites, hernial sites, gonads, and genitalia. Musculoskeletal system, we have to look for deformities, any test for developmental dysplasia of hip and club foot. Central nervous system, we have to look for the state of consciousness, vision, pupils, eye movement, facial sensations, hearing, sucking and swallowing, muscle tone, power, posture, and tendon reflexes. In the anthropometry, weight is measured on the weighing scale with a 10 gram sensitivity. We have already read this in the previous video. Length by the infantometer and head circumference by the soft non-stretchable tape circling the head just above the eyebrows and the occiput. Measure the chest circumference at the level of the nipples. Ponderal index is calculated by multiplying the weight in grams by 100 and then dividing the cube of length in centimeters. The mean birth weight of the Indian neonate at term gestation is approximately 2.9 kgs. The birth length and the head circumference are about 50 centimeters and 33 to 37 centimeters. These are the normal vital parameters in the neonates. First one is the heart rate. Term neonates heart rate is between 100 to 160 and preterm neonates heart rate is between 120 to 180 beats per minute. Relative bradycardia with heart rate as low as 80 beats per minute is normal in term neonates during sleep. Even as low as 80 beats per minute is also normal. Tachycardia suggests sepsis in anemia, fever or congestive cardiac failure. Tachycardia suggests what? Sepsis, anemia, fever or congestive cardiac failure. Now the axillary temperature in neonates is between 36.5 to 37.4 degrees centigrade. Axillary temperature is a good proxy for the core temperature of the baby. No need to measure the rectal temperature. Third one is the Capillary refill time should be less than or equal to 3 seconds. Prolonged CRT more than 3 seconds suggests poor circulation or in shock, as in shock or hypothermia. It's fine. Prolonged CRT suggests what? Shock or hypothermia. Assess the CRT on the sternum by pressing the skin with the ball of your finger for 5 seconds and then noting the time taken to refill. Okay, we have to press for 5 seconds. Coming to the respiratory rate, which is 40 to 60 breaths per minute, periodic breathing with a short apneic pause of 5 to 10 seconds is normal. A borderline count nearing 60 needs to be repeated. Apnea associated with the cyanosis or bradycardia is abnormal. Fine. If during the apneic pauses of 5 to 10 seconds, if there is any cyanosis which is appearing or bradycardia which is happening, that is abnormal. Okay. These are the new Ames intrauterine growth curve for boys and girls. Let's move ahead. An IUGR neonate showing wrinkled skin with the peeling. The difference between the head circumference and the chest circumference is usually less than 3 centimeters. And head circumference, chest circumference difference of more than 3 centimeters may indicate a IUGR in a term baby. Fine, this is how we are indicating an IUGR in term babies. Okay, how? The head circumference, chest circumference difference of more than 3 centimeters may indicate IUGR in term baby. Porer index is usually less than 2 in IUGR neonates and 2 or more in the appropriate for gestational age neonates. A large head is known as macrocephaly. Its causes include hydrocephalus like enlarged ventricles and overgrowth of the brain, bone or brain tissues. Now coming to the assessment of gestational age. Based on the gestation, neonates can be classified as preterm if less than 37 weeks, postterm if more than 32 weeks, and term between 37 to 41 weeks. The gestational age of the neonates can be assessed by the last menstrual period if the periods have been regular and reliability known by the first trimester ultrasound or newborn examination. The newborn examination for assessing the gestation requires an assessment of the physical features and the neurological maturity. Expanded New Ballard scores (ENBS), a commonly used scoring system, can provide gestation with an accuracy of 1 week. This is the expanded New Ballard score that these are the assessment of physical features and the neurological. Let's see in this image. Salient difference in the physical characteristics of the preterm and the term neonate. In the first one, A1, what we can see in the A1, we can see in the A there is a well curved pinna cartilage reaching up to the periphery. And in the B1 we can see flat and soft pinna cartilage is not reaching up to the periphery. See, here the cartilage is not present, but here the cartilage is present up to the periphery. In the C1 we can see well pigmented and pendulous scrotal sacs with fully descended testis. Fine, they are pigmented scrotal sacs with fully descended testis. And in the D1 we can see light pigmentation and not yet descended testis. Yeah. And see here the testes are not yet descended. Now in the we have done till the D1. In the E1, in this image, what we can see is deep transverse creases on the soles, right? And in the F1, what we can see, faint marks on the soles, no deep creases. Deep creases are absent here. Well-formed breast bud more than 5 mm is seen in the term babies, and poorly developed breast buds is seen in preterm babies. In the term babies, we can see silky hair where the individual strands can be made out, and in the preterm baby, we can see fuzzy hair. In females, in term babies, we can see labia majora covering the clitoris and labia minora, and in preterm babies there is prominent labia minora. Okay, moving ahead to the general examination. Skin, starting with skin and hair. This is the first one in general examination. Examine the skin for its thickness, color, transparency, and the presence of edema, rashes, and the lesions like hemangioma. The skin may exhibit minor features that are self-limiting. Assess the presence of jaundice by pressing the skin to reveal the yellow color of the subcutaneous tissue. Ecchymosis or the petechiae may relate to birth trauma. Examine the presence and the texture of the lanigo, the fine hair of the fetal period that is shed later. In this image, we will see lanigo hairs. Neonates have a significant seborrheic dermatitis in the initial few months that do not require any treatment. This is the lanigo hair. In the first image we can see in the preterm neonates, and in the B1 we can see seborrheic dermatitis, cradle cap, a large yellow pustule is also seen. Now in the first one, in general examination we saw about the skin and the hair. In the second one we will see about the head and the fontanelles. Examine the size and the shape of the head, the sutures, and the fontanelles. A small head indicates microcephaly. Caput succedaneum and cephalhematoma are the common findings in the normal neonates. Venous ventouse application can cause the formation of Finnegan in the neonates. A full and tense fontanelle in a quiet neonate is abnormal and may indicate meningitis, hydrocephalus, or intracranial hemorrhage. Okay. In the vertex presentation, the shape of the head may change and the skull bones may override. Sutural overriding, that's called during the process of vaginal birth. Large fontanelles and wide sutures are common in IUGR neonates. However, their presence can indicate increased intracranial pressure, trisomy 21, hypothyroidism, presence of what? Presence of large fontanelles and wide sutures can. This is important to remember. That large fontanelles and wide sutures, they are common in IUGR neonates. However, their presence can indicate increased intracranial pressure, trisomy 21, hypothyroidism, osteogenesis imperfecta in a normal neonate. Some neonates may have delayed ossification of the skull bones, and that may feel like a ping pong ball. Craniotabes, it is benign and resolves spontaneously. Now the third thing that we have to look for is the neck, face, eyes and ears. Examine the neck for masses such as enlarged thyroid gland and sternomastoid tumor, and the newborns have short necks. A birth injury can cause facial nerve paralysis, causing asymmetry of the face while the neonate is crying. The affected side have an open eye, absent nasolabial fold, and deviation of the angle of the mouth to the normal side. The absence of depressor anguli oris, DAOM, can mimic a facial paralysis. However, in this condition, the eyes remain tightly shut while crying, and the nasolabial fold is also intact. We will see in this figure. Examine the nose for its shape, secretions and patency. The flaring of the nostrils indicate an increase in the respiratory distress. See in this image, in the A1, there is absent depressor anguli oris muscle. In this, there is absent depressor anguli oris muscle, so there is facial asymmetry which can be seen, right? Note the asymmetry of the face on crying and the presence of the nasolabial fold and closed eyes. Yeah, nasolabial folds are present and eyes are closed. The uptick of the lower lip is typical of the condition. In the B image, we can see newborn with the right-sided lower motor nerve facial palsy secondary to the forceps application in the red arrow and the forceps mark in the black arrow. The upper lids of the baby looks puffy, which is often normal at the birth. See, there is facial asymmetry along with the absence of the nasolabial fold. The alveolar ridge may have natal teeth. A white papule at the apex of the hard palate is a retention cyst called as the Epstein pearl that disappears in few weeks. Subconjunctival hemorrhages are common after the vaginal delivery and resolve spontaneously. The cornea should be clear, pupils should be equal in size, reactive to light, and symmetrical. Accessory auricles and the preauricular tags are common. Now we read about neck, face, eyes and ears. Now let's read about the umbilicus, anus and the spine. Inspect the number of the vessels in the umbilical cord. A single umbilical artery is found in 0.7% of the live births, and this may be associated with renal and gastrointestinal tract anomalies. This is important to look at. A single umbilical artery is found in 0.7% of the live birth, and this is associated with renal and gastrointestinal tract anomalies. Palpate the base of the umbilical cord for a hernia. Palpate the spine with a finger to exclude spina bifida, masses and abnormal curvature. Check if the anal opening is intact. A sinus or a tuft of hair in the lumbosacral area may mark an underlying neural tube defect. This will be seen in 28.b. Let's see that image. In the first image, a sinus is shown by the arrow. In the A1, we can see a tuft of hair, and in the B1, we can see in the lower back may signify underlying neural tube defects. See, in the lower back, these are neural tube defects. Now coming to the fifth part, there is genitalia, male and female. Examine the genital area for the urethral opening in the clitoris. The presence of hymenal tags is innocuous finding. Examine the size and the curvature of the penis. Hypospadias implies more ventral location of the urethra. Normally it is located at the tip, and the presence of ventral incurvation, that is called chordae, and a deficient foreskin. Circumcision should be postponed in newborns with hypospadias. In this image, what we can see, base of a freshly cut umbilical cord shows two arteries in the black arrows and a vein in the red arrow. These are the two arteries and this is a vein. In this image, we can see umbilical hernia. We already saw this 28 image, and in this image we can see what? A newborn male with hypospadias. Note the presence of the chordae, ventral curvature of the penis. See, there is a ventral curvature of the penis which can be appreciated. Now coming to the extremities. Examine the arms and the limbs are fully movable with no evidence of the dislocation or asymmetry of the movements. Examine in this image what we can see, preaxial polydactyly. Yeah, right. Examine the fingers and the toes for abnormalities in the shape, size, or the number, syndactyly or polydactyly. A calcaneovalgus deformity is usually self-correcting within the next few months, but equinovarus requires orthopedic consultation, as seen in image 39.31a and b. In the A image, what can be seen? Congenital talipes equinovarus deformity. This is the CTEV, that is congenital talipes equinovarus deformity. And in the B image, what can be seen? A newborn delivered by the extended breech. Note the lower limbs with the extended knees and the flexed hips. Moving ahead, here. Now coming to the systemic examination. In the systemic examination, first we have to look at the chest. The anteroposterior diameter of the neonate's chest is roughly equal to the transverse diameter. Nasal flare, grunting, fast breathing, and the intercostal and subcostal retractions indicate respiratory distress. Such distress may reveal the presence of underlying pneumonia, respiratory distress syndrome, delayed reabsorption of the lung fluid, or any other cardiorespiratory cause. Stridor indicates large airway obstruction. Wheezing denotes small airway obstruction. The presence of bowel sounds in the chest may indicate congenital diaphragmatic hernia. Okay, this is again important to remember, that stridor indicates a larger airway. Wheezing denotes small airway obstruction. Fine, we have to look for the other signs like the nasal flaring, grunting, fast breathing, and the intercostal and subcostal retractions, which might indicate respiratory distress. And such distress are present in what? In the underlying pneumonia, respiratory distress syndrome, and delayed reabsorption of the lung fluids. Okay. As seen in transient tachypnea, of the newborn, and any cardiorespiratory cause also. Now, in cardiovascular system examination, what we have to look for? The presence of abnormal heart sounds or murmurs. Fine, and these may indicate congenital heart disease. Such neonates have tachypnea, cyanosis, or both. Bilateral femoral artery pulsations may be absent in the coarctation of aorta. Fine, this is also important to remember that bilateral femoral artery pulsations are absent in coarctation of aorta. Now the third one we have to examine is the abdomen. An unusual flatness or the scaphoid shape may be associated with the congenital diaphragmatic hernia. Visible gastric or the bowel patterns may indicate ileus or the intestinal obstruction. Normal neonates can have a liver palpable below the costal margin. Spleen tip and a left kidney lower pole may also be normally palpable. Now coming to the musculoskeletal system, the common alterations are deformations caused by the adverse mechanical factors. In utero, most positional deformities are mild and resolve in time. In this image, what can be seen? An abdominal distension is seen in the term neonate, suggestive of intestinal obstruction. A gastric tube, the arrow, shows drainage of bile, green in color. Now in this 9.32b, the preterm newborn showing abdominal distension with the visible bowel loops. The differential diagnosis includes sepsis, feed intolerance, necrotizing enterocolitis, and intestinal obstruction. These are all the DDs of a preterm neonate having abdominal distension. Okay. Moving ahead. Developmental dysplasia of the hip occurs in 1 in 800 live births, more commonly in the girls than those with the family history and delivered by the breech. This is examined by a Barlow maneuver and the Ortolani sign. First one is the Barlow's maneuver, in which Barlow's test is done to dislocate the unstable hip joint. We dislocate the unstable hip joint, test both the hips separately, stabilize the pelvis with one hand and with the thumb on the medial side of the thigh and the fingers on the greater trochanter. With the other hand, flex and adduct the hip. We have to do what? We have to flex and adduct the hip while applying posterior pressure to dislocate the hip. Okay, this is how the Barlow's maneuver is done, in which we are dislocating the unstable hip joint. And in the Ortolani sign, the sign is present if the hip is already dislocated. The neonate is placed on its back with the knees fully flexed and the hip flexed at the right angle. Test both the hips separately. Stabilize the pelvis with one hand and with the thumb on the medial side of the thigh and the fingers on the greater trochanter. Abduct. In the above one, we adducted the hip. In this one, we have to abduct the thigh and push the femoral head anteriorly with your fingers. In the dislocated hip, the femoral head suddenly slips into the acetabulum with a distantly palpable clunk. Now coming to the neurological examination, consists of assessing the level of alertness. What we have to do in neurological examination, we have to assess the level of alertness, cranial nerves, motor in the sensory system, and the neonatal reflexes. First one is the cranial nerves. Neonate respond to the cotton soaked peppermint by 32 weeks of gestation. By 26 weeks, the infant consistently blinks in response to light. And by the term gestation, fixation and following tested using a fluffy red yarn ball are well established. By 28 weeks, the infant startles or blinks at a loud noise. Normal sucking in the swallowing denote proper functioning of 5th, 7th, 9th and 10th and 12th cranial nerves. Okay, this is important to remember. Normal sucking and swallowing, these cranial nerves are proper, and By 28 weeks, the infant startles or blinks at loud noises. Okay, neonate respond to cotton soaked peppermint by 32 weeks of gestation. By 26 weeks, a infant consistently blinks in response to light. Okay, 26 weeks, consistently blinks in response to light, and by the term gestation, fixation, and following, which is tested by fluffy red yarn ball. Okay, now feeding requires the coordination action of the sucking, swallowing, and breathing. Suck swallow coordination is accepted, except pallidi feeding is present by 32 weeks. Okay, we can start the pallidi feeding because the suck swallow coordination is developed by 32 weeks. Suck swallow and breathing coordination for the breastfeeding to occurs by 34 weeks. Okay. However, perfect coordination of the suck swallow and breathing develops only by 38 weeks of gestation. Okay. Now coming to the motor examination. This was all about cranial nerves. Now coming to the motor examination. By 28 weeks, there is a minimal resistance to passive manipulation of all the limbs, and the distinct flexor tone is appreciated in the lower extremities by 32 weeks. By 36 weeks, flexor tone is palpable in both the lower and the upper extremities. Okay, this flexor tone is palpable in both 36 weeks in both the lower and the upper extremities. Now coming to the primary neonatal reflexes. To elicit the Moro's reflex, first one we are going to read about is the Moro's reflex. Raise the baby's head slightly and drop it suddenly while the hand still supports the neonate. The response consists of opening of the hands and extension and abduction of the upper extremities, followed by anterior flexion, embracing of the upper extremities with an audible cry. This was the Moro's reflex. The hand opening is present by 28 weeks, extension and abduction by 32 weeks, and anterior flexion by 37 weeks. These are the parts of Moro's reflex. Okay, so the Moro's reflex is completely developed by 37 weeks. Hand opening is present by 28 weeks, extension and abduction by 32 weeks, and anterior flexion is present by 37 weeks. Moro's reflex disappears by 3 to 6 months in a normal infant. Okay, Moro's reflex disappears by 3 to 6 months in a normal infant. The most common cause of the depressed or the absent Moro's reflex is generalized disturbance in the central nervous system, and asymmetrical Moro's reflex indicates root plexus injury. Okay, asymmetrical Moro's reflex represent what? Root plexus injury. Now, the first reflex that we read about was the Moro's reflex. The second reflex is the palmar grasp, is present at 28 weeks of gestation and strong by 32 weeks. Palmar grasp is strong enough to allow the lifting of the neonate at 37 weeks of gestation. It becomes less consistent and allows the appearance of the voluntary grasp at 4 months. Let's look at these images first. In the first one, we can see abduction and extension of the arms. See, abduction. And in the second one, there is adduction and flexion. And in the C, there is asymmetric Moro's reflex in the brachial plexus injury. As the Erb's palsy on the right side, the upper limb does not move. In this, we can see the palmar grasp. Moving ahead, the asymmetric tonic neck response is an important response elicited by the head rotation that causes the extension of the upper extremity on the side to the face and the flexion of the upper extremity on the opposite side. Fine. So on the side of the head rotation, that causes the extension of the upper limb on the same side. This is asymmetric tonic neck reflex. Third reflex. So this was all about the neonatal reflexes. Let's revise the headings only that we read about. We read a lot in this video. Fine. So let's start with, we read from evaluation of the newborn. We read about the general observation, about the vital signs, assessment of the size and the growth, and newborn history and examination, and the formal case presentation we read in this. In the anthropometry, we read about the vital parameters like the heart rate. In the term, it is 100 to 160. Axillary temperature is 36.5 to 37.4. Capillary refill time less than 3 seconds, and respiratory rate 40 to 60. Now we read about the head circumference, which is usually less than 3 centimeter, and if it is more than 3 centimeter, it indicates an IUGR baby. Ponder index is less than 2 in the IUGR. Okay. Now we read about the assessment of the gestational age. We saw differences between the term and the preterm via these images. Then on the general examination, we read about the skin and hair, about the head and the fontanelles. Large fontanelles and wide sutures are common in IUGR, but they can also be their presence can also indicate increased intracranial pressure, trisomy 21, hypothyroidism, and osteogenesis imperfecta. We saw the examination of neck, face, eyes, and ears. In the umbilicus, if the single umbilical artery, which is found in 0.7% of the live birth, they may be associated with the renal and the gastrointestinal anomalies. We saw about the genitals in the male and female both. Now, in systemic examination, we saw about the chest, cardiovascular system. If bilateral femoral artery pulsation are absent, they are seen in coarctation of aorta. In the abdomen, if abnormal flatness or scaphoid shape, seen in congenital diaphragmatic hernia. Okay, in the musculoskeletal system, we saw about the developmental dysplasia of the hip and the two maneuvers which can help to examine it. But that is the Barlow's maneuver and the Ortolani sign. In the neurological examination, we saw about the cranial nerves. Motor examination in the primary neonatal reflexes like Moro's palmar grasp and the asymmetric tonic neck reflex. This was all about this video. Thank you.